And welcome to this week's episode of The Dental Guys. I'm Wes the Dental Guy.
John the Dental Guy, and this has been a great week of podcasting, but it's really been a tough week in some ways too, because we have had so much that has been happening and trying to keep up with all of it. And then we've got our own practices that we're thinking about. What do we do? And really, I've found that this podcast world that we've kind of had here, Wes, has been a huge help for me in trying to come up with a game plan, make sure I'm doing the right things. And it's been amazing to see how our numbers have grown, listeners have grown, kind of different audiences, as everybody right now is asking the same questions, Wes. And that's what we're going to be talking about tonight.
Were you reading my mind today? Because today I was talking to someone on the phone and they said, man, you have, done all these things. How have you done all those things to prepare for reopening your office? And I said, it's because of my podcast. I said, one of the things that we remember that Dr. Brannemark said was to surround yourself, John, with people that are better than you, smarter than you, and guess what? You're bound to succeed. And that's what we're doing tonight, is we're going to surround ourselves with someone that is just high level, and I'm super excited about this because does the science matter, right? And when we return to work, what are you going to tell your team about the science, right? About why
and then the big thing, and the big thing that we really have had, I think we've learned over this last week as we've been doing a lot of podcasting, is people are very interested in these questions. They want to know, what does the science actually say? And you saw that in kind of our intro and our topic. And we're bringing somebody to you guys tonight who is very well versed in that science of what should we be doing? What do we know? What don't we know? So welcome, Dr. Robert Lemke. We're so glad to have you with us tonight on the Dental Guys.
Well, thank you. And what an honor. I mean, I'm excited to be here. It's my privilege to be with you guys. I mean, quite honestly, that's where it all starts, with the practice and the day-to-day and seeing everything from the little things to the challenging things. I mean, you guys are what brings it home.
Well, let me just tell you a little bit about Dr. Lemke, John. Dr. Lemke, he's board-certified oral surgeon. He was born and raised in San Antonio, Texas, and he's a graduate of Trinity University and the University of Texas Health Science Center. He holds dual degrees. He's both a doctor of dental surgery and a medical doctor, and he completed his oral maxillary surgery training there at that Texas Health Sciences Center. He's also published, which we love that, and he's published more than 13 scientific abstracts on facial surgery and contributed chapters to books and lecturing nationally and even preparing lectures as we speak. And, one of the things that John was working on today was a teeth-in-a-day procedure, and that's one of the things that Dr. Lemke loves and he loves to talk about. But, more importantly, he has a balance, and I like balance in life. He has a family where he does things outside the office. He enjoys cycling, running, and he also is a published photographer, John. So some of the same things that we like, Robert Lemke likes. He sits on the board of the Academy of Osseointegration, and then also he's a past chairman of the AO Research Committee, which we just love research, and we've talked about in pre-production. John, talk about some of the things leading up to this and this discussion.
Yeah, I mean, it sounds like Dr. Lemke is a fellow nerd, right? And I mean that with all the best intentions, right? Because anybody that is really committed, like we are, to reading the journals and really dealing with the science fits well with us. And so we're going to take a little journey today through some of the science. And what's led up to this discussion tonight has been the whirlwind of the last few weeks of guidance, guidelines, toolkits, recommendations, discussions, OSHA, CDC, American Dental Association, all the state dental associations, all of these things have come together to get these questions in our minds about what do we do to go back to work as we return to work. And the biggest thing that we want to talk about today is, where is the evidence? And if there's one question we could sort of answer or try to answer tonight, it's how much of what we are doing to protect our patients, our team, and ourselves is based upon evidence and science. How much of it is based upon fear? How much of it is based on the unknown? And that doesn't necessarily mean that the unknown we shouldn't prepare for, but we want to dive into this. And I think the first thing we want to talk about is masks, because everybody's been talking so much about masks. And OSHA has said that we are supposed to have NIOSH approved N95 masks for aerosol generating procedures. Tell us a little bit about your thoughts on that recommendation and a little bit about the science behind that recommendation. And, there's other guidelines we've kind of been hearing about, and let's kind of talk it through. Where is the science bringing us? How have we gotten to that point? What are your thoughts on that?
Well, those are excellent questions, and it's hard to even know where to begin to answer some of that, because obviously, there's never been a pandemic like this in our society with what we now have current in regards to technology. And so trying to find a balance between what we know and what we have and what we don't know is really challenging. But what we know is that in general, we've always been used to wearing masks for the last, 15, 25 years or so. And of course, there's levels of masks and there's surgical masks. But the bottom line is that all of those masks are there to protect us from either blood splatter or from us coughing onto a surgical field. If we're a surgeon or if we're a dentist and, sneezing in someone's face, somehow those patients don't tend to come back. And so now, though, when we have this invisible war against a virus, it's in a different area. It's in a different field where we need to think, besides just a little droplet of blood or a coughing, we need to think about airborne issues. And that's where the N95 masks come in, or KN95 masks, because they form a better seal with the double elastics. So from a practical standpoint, those are protecting us from the environment, as opposed to a surgical mask, which tends to protect more the environment from us. And so their recommendation originally was, well, you don't even need a mask. And then they said, well, wear masks if they have COVID. Well, we all know that there's a lot of asymptomatic sheddings of the viral disease. And so now, if you can get a mask, wear a mask. And then that's, of course, the challenge of getting a mask. So,
yeah. So that to answer that question, we have to dive deeper then into this discussion of, what, before we talk about getting the mask, because I think that's another excellent thing to talk through, and how to know that you have a real one and those types of things. But what, you mentioned, how this has changed and kind of gone up, and we everybody, I think, knows about levels of masks now. Even people that didn't 6 months ago are now very familiar with level 3 masks and level 2 masks and those ideas. But, when we were given this toolkit by the American Dental Association, they talked, and some guidance on mask types. They talked about surgical mask with a face shield. And I think the thing that we keep hearing coming up, one of our top kind of questions that keeps coming up is there science to indicate or show us that a surgical mask with a face shield is effective at preventing virus transmission? And how much more is an N95 effective in a clinical setting? Because there's been some interesting studies, right? Let's talk about some of those studies. What do we know about surgical masks versus respirators when it comes to transmission of viruses?
So excellent question. In regards to that one question of what we know about surgical masks versus N95 masks, Long and others, just this last year in 2020, put out an article where he looked at retrospectively lots of studies that looked at influenza, mostly influenza A, historically, and the protection that either a surgical mask or an N95 mask gave to the individual, to the healthcare provider. And after analyzing all of this and then looking to see if that healthcare provider was by laboratory verified to have influenza, they found that there was no difference between a surgical mask and an N95 mask. So at first you say, oh, well, why even use a surgical mask? But if you dive even deeper, it may be that the surgical masks weren't used correctly, or that the N95 masks weren't used correctly. So there's so many aspects, and usually the weakest link is not necessarily the mask, but it's us. But I can tell you that we actually did some studies just even in our own office. Looked at filtration of smoke through the mask. And when you wear a surgical mask, it just comes out completely in or out from the sides. And so from an airborne standpoint, that doesn't help. Now, studies regarding face shields show that for the most part, the splatter comes right down the center. And originally I would have thought, well, if you're right-handed and you're on the right side of the patient, you get more splatter on one side, but it wasn't. It wasn't affected by left or right-handedness. It was really down the center, down around the eyes, around the nose and the mouth area. And so face masks were very important, but even in one study, they showed that there was some penetration underneath and behind the face shield. So wearing a face shield alone is not sufficient. Wearing a surgical mask that's open is not sufficient. And so the recommendation is wear an N95 mask that seals and a face shield that protects from the splatter.
You know, and I think the interesting thing here, this is one of the reasons why that a respiratory protection program is necessary. And that's what OSHA requires for team members that are going to wear a respirator now have to go through a respiratory protection, which is a simple thing to do. But then what's a part of that now is what we call a fit test, right? And a fit test is an evaluation of the seal around your face. And for some individuals, you might have masks that don't fit correctly, that do have gaps. And then also, you actually don a hood with smells, like they crack smells, banana smells, and things like that.
Yeah, smoke and things like that.
Smoke and things like that, which is an indication of good fit. Once you've passed a fit test and even a medical exam to say that you can wear, right, a respirator, then now you know the brand, the size, the shape of that respirator that's appropriate for you. The issue then, I guess, is right now, if we have N95s and we're doing aerosol generating procedures, is that better than a level 3? What does the science say?
Yeah, because the study you mentioned, they didn't find a difference in contracting influenza, right? With those two different types of, even though we know there is a better seal, and we know that there is, obviously on the bench top, if you will, a better performance of this respirator. It didn't seem to translate, at least in that study, into a protection difference. So does that mean that it's overkill? Not that, obviously the guidelines tell us we have to do it. And that's the end of it, really. But when we're talking about the science, do you feel like we're going to see that roll back because of this? Or obviously we need more studies. Are there studies out there that would say that an N95 is superior, not just on the benchtop, but actually in a clinical setting? Do we have those studies?
There's not a lot of studies out, and thanks, John. That is an excellent question, because it gets at the heart of, is there a statistical difference if used, as Wes said, correctly? And I'm talking to a dentist in Dallas, and she was explaining that for a fit test, and it took multiple tries and resizing and getting a smaller size mask before they could find one that actually fit and it was not leaking. And she said, I can't remember if it was 3 or 5 different tries, or maybe it was even 7, but it was multiple tries. And she said, finally, when it did fit correctly, it was uncomfortable. We all go to the stores, and we see people with their masks, below their nose, or I saw one with it on their nose, but their mouth was open. And someone said that they were at a store, and someone pulled the mask down, sneezed, and then put it back. And someone said, "Why did you do that?" "Oh, I didn't want to get my mask dirty."
Yeah.
And so human error is ultimately where it's at. And so if we can have an N95 mask that is not counterfeit and that is fit tested and works, that is wonderful. If not, we have to try to do with what we have. But you mentioned the difference, and there was a really good study by Fan and others in 2019, and this one just blew me away.
It's awesome.
And what they did is they took 59 healthcare workers, and they said, okay, you're treating influenza patients. That's great. You're going to wear a gown, you're going to wear gloves, a face mask, and you're a doctor or you're a nurse. So you're going to have a stethoscope. So go out and treat them. And at the end of the day, come on back. So they did. And they swabbed them doing the RT-PCR test for the virus, the RNA of the virus, the influenza virus. And they swabbed their gloves. They swabbed their mask. They swapped their gowns and their stethoscopes. And then they said, okay, go ahead and doff, remove the wear. And then they re-swabbed them. They re-swabbed their face. They swabbed their hands. They swabbed their scrubs. And amazing, there was statistically essentially no difference. 31% of the gloves showed virus on it. And when they were removed and they tested the bare hand, 21% showed virus. And then of the gowns, 21% was positive. And when they removed it and swabbed the scrubs, which, they go home in sometimes or go to the grocery store and buy things on the way home, 11% showed the virus. And 12% of the face masks showed virus, and 7% of the face had virus. So, you all can figure out.
Wow.
It's not that the face mask had a hole in it. What was going on? We all know.
Right. So is it more important how we're putting on and taking off our gear than it is what type of gear we have in some ways? Does that maybe have, that study would seem to indicate, if we don't have data right now that clearly says, right, that a N95 versus a surgical mask, that there's a statistical difference. This study, though, seems to say that this is really maybe where we need to concentrate our effort to improve, is how to safely put on and take off the gear. And you talked about this in a previous AO webinar about, how to actually do this. In fact, there's even a video out there, which you can go back and look at on the AO's feed, where you go through how you guys are putting on, taking off your gear. But that's interesting to think that really that may be where, do you think that that's the area that we're missing the most?
I think we need to start there, because if we had all the fancy masks and all the fancy face shields, it's worthless if we don't use it correctly. So we need to start off, as we all know, with the basics. And you can even take a surgical mask and put a little piece of tape and probably get as good a fit with some tape along the sides and a face shield as you're going to get with an N95 mask that's not appropriately put on.
Well, that's interesting. And I'll just say we had a question from one of our listeners who's watching this right now, that goes right to that, which is, there's been, I'm sure seen these neat, you can use Bellis 3D face scanning technology, 3D print a frame that better seals a level 3 mask. And based on what you're telling us now, it sounds like maybe that could solve a lot of our problems with the mask. Has there been any, I don't know if is that so new that there's really not a lot of information out there? Because there's people asking, hey, if I don't have N95s or KN95s, what do I do? Do you think that that's essentially like a work practice control, if you will, from OSHA standpoint, that maybe we could make
engineering? You're making your good faith best effort with what we have right now.
Do you think that's reasonable, or are we just trying to push this to get away from doing what OSHA says or something?
No, I think it's absolutely reasonable, especially if you can't get a real mask. And that's a whole nother category. I can tell you that, it's one of those classic things. You look everywhere online, you can't find them. You call, your big dental distributors, they can't get them for 2 or 3 months. And so, I had a friend in Austin who knew someone in Florida who is a pharmacist who, they could get them for me. And, it's already sounding bad, right? But, you're desperate, right? We're all desperate. We want them. So, okay, I sent my $500 for my limited minimum order of 100 masks. Yes. And here they came back. And the outside of the box, okay, first of all, it looked like a little Kleenex box, okay, about this big, and it had 10 of them in. That's a bad start. It said Dollar Tree on the outside.
Oh, no. Oh, no.
And I paid far more than $1, okay, per mask. And then we put them on, and it only had the ear loops. And I just questioned it. So I was very critical, and I contacted the guy back, and I was kind of a little niffed. And he said, oh, no, see, they're stamped KN95. And it's like, oh, I guess they are. Well, then we did our own test, and that's on our Instagram, Advanced Oral Surgery SA, where we actually had someone blow smoke through, and we had a 3M ventilator, respirator. Nothing came through. And they put on that other counterfeit one, which I didn't know at the time was counterfeit, and it was like a sieve. I mean, smoke just came out everywhere. And I had given some of them to some of my referrals. And now I felt bad because here I'm trying to help them, and yet I think I put them at more risk by giving them a false sense of security. Yep. And so, like you say, having a good level 3 surgical mask when we did the test was far better, especially if you tape it, than this worthless counterfeit KN95 mask.
We had a good conversation about just this last week, Dr. Lemke, and you talked a little bit about dentists and the fact that we are doing these donning and doffing procedures so many times during the day. And there's going to be a lot of innovation come out over the next even months to year regarding what we're talking about. It's probably going to change really medicine for the better. But you talked about how dentistry could be the leaders in this, right? And I think I'd like to hear your thoughts on that is, how do we lead, right? And one, I don't want us to, I want you to speak to that just a little bit, and then I might follow up with a little commentary.
Well, I mean, in general, dentists tend to be leaders anyway in the community. We tend to be more vocal than medical doctors in general. But in this situation with COVID, we're kind of forced to be leaders. And we talked about, there's something that people can look up. It's by the Department of Labor. And they looked at risk of COVID based on essentially employment, what you did. And the interesting thing was, on the x-axis was the percentage of risk that you would have of getting COVID, essentially, 0 to 100%. And on the y-axis, they looked at income, low income versus high. And you can imagine, if you're a CEO and you're sitting back in the office and just looking at numbers, well, your risk is very, very low, maybe 4 or 5%, and your income is high. If you're a web designer, well, you're not going to make as much as a CEO, and they're in the middle, but their risk is still low because they're not interacting with anyone. If you looked at taxi cab drivers, well, the traditional ones, not the Ubers of the world, but they had the plastic sheets behind them. Their windows could be open. They're actually in the same 4, 5, 6%. But of course, we know who is on the other extreme. In fact, at 99.7% risk of COVID was dental hygienists. And Wes, we were talking earlier about how so many dental hygienists are now listening in, which is so smart of them because they are the forefronts. They are the, those are the Marines. They're in the, front lines of the front lines. And so the more dental hygienists that get on board and ask questions, the better. Second was dental assistants. So they need to be listening to these talks. And they came in at about 93%. And third, what was us, dentists, at 92%. And medical doctors, they fell farther down. But it was based on 3 different factors, number of exposures, proximity, and the type of procedures that create aerosols. And well, that's us. So we're forced to be a leader because if we're not, well, we're just going to get sick, or we're going to have to fold our little arms and close our practices. And we don't want to do either of those two. So each one of us, I mean, you guys are examples of leaders. I mean, you guys are spectacular. The AO has really pushed forward in education. And those are the types of people that, boy, I mean, I really admire you guys and them for setting examples, for setting standards, for asking questions. We may not have the answers, but asking the questions and moving us in the right directions.
Do you think I totally agree. I think we have so much opportunity here to lead, and it's been hard to watch in some ways because I feel like there's been because of a lot of fear and because of conflicts of interest, because there are conflicts of interest. We know this that people have, in some ways, I think stress has bred out the worst in some, and I think that can lead to kind of separation in the community, when really this is a chance for us to come together around the science and around the positive side of this of, hey, we have the ability here to innovate. We have the ability to learn together on what works. If you come back to this question, you had mentioned earlier about the difficulty of getting PPE and getting masks specifically, which seems to be kind of the rate limiting step in this whole thing is the masks. We can get most of the other things. What do you tell someone who has some masks and they're asking the question of how can I safely reuse the masks that I have? What are some ways that are safe and proven that people, and is it safe? Is it proven? I think there's people still asking that question.
It's a good question, and there's not a lot of answers out yet. But what I can say is that people tried various things. I mean, the standard autoclaving of masks, and for that matter, gowns can be done. The problem with the gowns, just as a sideline, is that the buttons tend to melt onto the fabric. And so you have to be careful with that and insulate them. But if you do a certain few steps, then you can actually recycle the gowns by sterilizing them. So that's one thing. For masks, what I've started doing, and I've been doing literally for since day one of this COVID, so about a month now, is we have a UV sterilization box that it looks like a bread box. And I literally call it, where's our bread box in our office? And you open it up and it has mirrored surfaces on the inside. It has a little grate that lifts it up. And then we put our masks in between every case and leave it for 20 minutes. And the UVC light, sterilizes it and kills bacteria, fungal aspects, fungi, and virucidal. And so that's one thing that we do. Another one that's a little off the cuff is microwaves. Now, the interesting thing about microwaves is way back when, you guys, I don't know, you guys are younger than I am. You probably remember the old VHS versus Beta.
Oh,
remember
yeah.
that?
Oh, yeah.
Oh, yeah. It was a war.
Okay.
That was a big deal.
It was a classic one.
That's right. That's right. It was a war, Wes. So give us in a minute or 20 seconds about the war. And I'll use that as a springboard.
Yeah, so I remember my friends had Betamax, okay? And they were like, this is going to be it. And I remember,
let me just say just one thing, Robert. You've asked the right person this question. I just want to let you know that. So proceed. Wes.
And my dad was an early adopter of like the VHS camcorder that like you had the shoulder harness carrying and you carried it out.
It was like a
to,
bazooka.
Like, the family picnic. And he was like, son, it's going to be VHS. I know it is. They're wrong. And that's how passionate people got about this Beta VHS thing. But we digressed a little bit for that nostalgia, right, that we love. Let's come back to the UV lights and the microwaves.
Well, that's right. So it was a competition between the two, and people were fervent about it. And you know, one out over the other. Well, the same competition happened back in the 70s with microwave ovens. And so two different frequencies. I believe it was like 2450, and I can't remember the other one. And one was put out by Raytheon, and the other one by General Electric. And they were competing, and they're very different wavelengths, so they did different things. Now, one was a big, heavy unit, and it would penetrate deeper. So you could put the whole turkey in. I know you're probably wondering, where are we going with this conversation, right? Anyway, you could put the whole turkey in, and it would penetrate all the way and cook it, and it was great. But most people were cooking turkeys in their microwave. They were throwing in the pizza. So actually, the company, and I can't remember which one was which, but the one that had these shorter wavelength that just penetrated only about 1 inch to 2 inches at the most, won out, and that's what we have. Well, were studies though that looked at using microwaves to kill, because it is bactericidal and virucidal. In fact, there was a study back in the 1980s that looked at nasal hoods from, nitrous oxygen masks. And they actually put it in the microwave, and they modified the microwave a little bit, and they coated it with virus and hepatitis and various viruses. And they found that after 3 minutes, well, actually 1 minute, significant numbers decreased, but after about 3 to 4 minutes, depending on the two different studies, all the virus was essentially dead. And so I thought, wow, that's great. Now, the FDA does not authorize or state that microwaves should be used unless it's the older microwave, which penetrates better. And so actually that has been FDA authorized for milk and other food products because it can penetrate. Okay. But nonetheless, I thought, wow, this is great. Like you guys always trying to think a little crazy and a little off the cuff. I thought, we're going to take masks and put them in. And my staffer's like, no, Dr. Lemke, you can't put any metal. And I get a fork and I put it in and I show them you can use a fork, and as long as there's no arcing, no problem. And they think I'm crazy, but you can do that. So I told my mom, well, she said to say she's only above 80. Okay. So I can't use any more, but she's above 80. And I gave her a pink mask, and I told her, Mom, you can just throw it in the microwave. Well, Mom did that. I actually have the mask here.
Awesome.
I don't know if you can see the mask.
Oh, oh no. Oh no.
Oh my.
Yeah, it started on fire.
Did you buy your mom a new microwave?
The son kills mother by fire in microwave. Sterilizing face mask almost came out. But Mom got a spatula and hit it a few times. Anyway, what I kind of left out was that this and the cotton heated up and it caused a fire. So other than that, it actually works well if you remove the metal. Anyway, so that's kind of a little far-fetched, but there are various techniques. UVC light can do it. There's also different hydrogen peroxide gases that are being studied. The old classic ethylene dioxide gas can be used, and some hospitals have that. So all of those are techniques. I would not recommend. I don't want anyone's mother dying from fires in their kitchen. So don't recommend that. Now, if it's all cloth, it probably will work, but it didn't come from me. Okay.
Right.
Yeah. Yeah. And I know there's even been too the technique of just leaving the masks out after they've been used. So you can hang the mask or put it in a paper bag and leave it for 3 days, and the virus can only live for a certain amount of time. And so if you have enough, I guess you could, that's kind of what we've been doing with some of ours that are limited, is, putting them in a bag, and this is the Monday mask, and you don't touch that mask again until, next Monday. And I think there's hospitals that have been doing that as well. Obviously not nearly as good. We've got a UV light box coming. I'm interested to see, how quick that, let me ask you about that. How quick is that? Do you know how long is that cycle?
20 minutes. And the studies confirm that. So 20 minutes in that light box with the UV is adequate for virucidal effects. We've taken that a step further. We ended up getting the UV light, just the light, and it's about, I think, 60 watts. And I thought, 60 watts is nothing. But oh my gosh, I mean, it almost blinds you. And we actually, between each patient, that's one of the things we do. And we can talk about that later, the different steps. But we actually put that light in every room so that we don't have to wait 3 to 4 hours. We have a 30-minute cycle of turning over rooms. And actually, the studies show really 20 minutes is all that's necessary, but we do an extra 50% just to be on the safe side.
Interesting.
That's
interesting. So
technique.
And that's that. Let's talk about some of the other things you're doing in your practice. I'm interested to hear, just some of the things that you've implemented, some of which might be things we all already kind of know about, but if there are other things that are maybe things that you've either discovered or you've kind of put in place as kind of a, an extra precaution, walk us through a little bit of that.
Sure. So we divided it into 4 sections. Okay. The first is the pre-patient. The second is just immediately prior to surgery. The third is actually surgical aspects. And the fourth is actually after surgery, which is also important and we tend to forget about in general. So pre-surgical, we try to decrease our exposure with patients. So where possible, we're doing teledentistry. Now, I'll be honest, in the state of Texas, the Texas State Board of Dental Examiners clearly states teledentistry is not allowed. So we're just doing screenings, okay? And it gives me an opportunity to spend time with a patient. I mean, we all enter dentistry because we enjoy being with people. And you guys are probably the kind that sit and you get to know your patient before you even start or look in their mouth. And that's most of dentists. And so this gives me that opportunity to do that, but in a safe environment in my office, enclosed. And so we do video conferencing. That's the first thing that we'll do. Second is when the patient comes, we actually have them call us from outside. We send a staff member with a mask on, takes their temperature. Now, temperature is a whole nother issue if we want to talk about that and the inconsistency of temperatures and infrared versus digital, and that's a whole nother conversation. But we take their temperature. Okay. And then we only allow that patient to come in. Family members and aunts and uncles and whatnot, they have to wait outside or out in a car. Okay. So that one person comes in at a time. They have to put on a mask outside. Now, nowadays, most people have their own masks, so they wear their mask in. We go through the screening questions, and those are real important because we don't limit them to the old classic questions, which were, have you traveled? Well, nowadays, no one's traveling, right? So that's almost a ridiculous question. But still, have you traveled? But then we go into the actual, have you had a cough? Do you have a fever? But more important, are the symptoms that are associated with COVID. And that's everything from the cough aspects and the temperature, as we mentioned, but also the diarrhea, loss of smell or taste. All of those are important to ask. So we go through all of those even before someone comes in. And then if they can make it that far, and we know that asymptomatic people can still be carriers, then we go into this surgical room. Okay, well, we're already gowned. We don't put our gown on in front, and we actually have the patients use a mouthwash. And I'd say most general dentists probably have their patients use a mouthwash. But there was a study that looked at not COVID-19, but SARS and MERS, which were other variations of the coronavirus. And they looked at the ability to kill it with alcohol and hydrogen peroxide and all these different things, and chlorhexidine. And chlorhexidine did work, but there was one small catch. It takes 10 minutes.
Okay.
So just imagine your staff saying, only 7 more minutes.
Yeah.
Okay, you're down to 5.
Exactly.
Oh, no, you're losing it. It just can't work.
Oh, man. Yeah.
So it's a good idea, but it's just not going to work. Well, hydrogen peroxide actually within 1 minute kills. So I told my son this at dinner, and he's a college student, and he laughed and he said, so you're going to offer free whitening too, right, Dad?
There you go. Now, why did the ADA take that out of the toolkit? They were saying that early on, before we were kind of shut down, they said, hey, you should do this. And now with the new toolkit, they seem to indicate that the studies don't support that. Has something changed? Because it seems strange to us.
It seems strange to me too. So quite honestly, you guys hit, especially you, John, you mentioned that there's so many factors. And Wes, we were talking about it. There's political, there's economic, there's social, there's geographic, so many, religious too. And we don't want to get into politics, sex, and religion, but I hate to say it, you almost kind of have to, because it affects us indirectly and directly in our practices with this pandemic. And so with that, I mean, when the World Health Organization and when the CDC were saying, oh, you don't need masks, it wasn't really based on science, but availability and not wanting everyone to run out and buy masks so that the healthcare providers couldn't use it. So it was other factors than science. I mean, is practicality. And so hydrogen peroxide, that's what we're doing. I mean, we're doing a minute of chlorhexidine mix 50-50 with hydrogen peroxide. Now, is it going to kill everything? No, of course. It's in their lungs. It's in their nasal respiratory system. It's not. But that we'll never get rid of it 100%. So if you think of everything as a bell curve, where do we want to be? Well, we want to push ourselves to be in the area of maximum safety. We'll never get to 100% safe, but what can we do to get there? So we do the mouth rinse. We also get just a 4x4 gauze. Now, okay, my patients are sedated, okay, but we lay it across their nose so that nothing from their nose is breathing out, especially if they sneezed, okay, and we're right in front. Okay. Again, my patient is sedated, so I use a mouth, essentially a gauze in the back as a throat to help prevent from any aspiration of materials, but also to prevent large droplets from me. Now, what general dentists can do are all those other systems, the isolites and the, I don't know. I mean, you probably know all the different systems better than I do.
Sure. Yeah.
So that can decrease. And what are some of the other systems?
Yeah, there's a product called Isovac from, and Isolite is the same thing. Isodry from Xyrus.
Mr. Thirsty from Zerk. There's a new one that came out. Yeah, there's a new one that came out that's called Relief, which is for people that can't tolerate something that goes all the way across the back of the mouth, of course, for the non-sedated patients. It sits in the cheek, in the vestibule, and it's connected to high volume suction. There were a couple of those that were out before that were saliva ejector compatible.
That's
but this is the first one that's that's compatible with high volume suction. And there's a number of other, you know, dry shield. I mean, there's a ton of them that have kind of the same idea. And I think you're right. You know, having something that could actually cover across the mouth is probably ideal.
Rubber dam.
Right. And then there's rubber dam isolation. Yeah. I mean, we've kind of, we don't want to forget about that too quick. Yeah. That's exactly right. Exactly.
So you've got the patient now, you know, here's the thing that what you've done, right, is again, this bell curve you talk about, I think we forget about this all so often, is that you are now, with all the questioning, with the temperature taking, with the procedure of, you know, walking the patient back, having them rinse and wash their hands or use some type of alcohol-based hand sanitizer, and then you get them in the operatory and you are rinsing with a hydrogen peroxide-based solution, and you're setting them in the chair. You're not touching the patient's hands. You're not doing anything other than just getting the patient back, and you've screened them to this point. You've taken all those precautions. You talk about shifting a bell curve. It really starts to eliminate some of the chances of spreading this to yourself, to your team, to other people, to where it becomes almost a minuscule chance that you might get this. Is that what the science is saying? And that's what we're trying to do during this mitigation phase.
That's it. It's just risk management. And there's so many steps, you know, generally 4 or 5 steps to risk management: identifying the risk, following through, establishing a protocol, monitoring to see if that's working, and then starting all over. And so it's risk management to decrease our risk. We'll never remove it. I mean, we know as dentists, I mean, we went into the field knowing that there's always a risk. It's a little higher now, but we're trying to get it back to what we're comfortable with. And everyone's going to be a little different regarding comfort. Now, the hydrogen peroxide, I think we have to be a little careful. Again, I'm going to be using it, but we have to be careful that it's not in there too long, or that it's too, you know, that it's all 100%. And I say that because I remember, I'll tell a little story. Years ago, an elderly lady fell on the ground and she cut up her whole scalp. And I spent probably about 2 or 3 hours stitching and putting everything back together. And I was so proud. I was, you know, patting myself on the back, and so excited for her. Well, she lived out of town, and she came back about 3 or 4 weeks afterwards for some suture removal. Well, it's a little late, but better late than never. And I looked at her and I saw skull. I mean, literally just her bone exposed right there. And it's one of those cases where, how do you try to be professional and not let your jaw drop, okay? And go, oh my, you know, that happens every now and then, but you try to be professional. And I said, what happened? And she said, what do you mean? Well, it was all healed or put together. I mean, words were losing me, right? When I'm looking at her skull exposed. I mean, like, you know, and she said, well, I cleaned it every day, 2 or 3 times a day. Well, what with? Hydrogen peroxide. And so hydrogen peroxide is great because it kills, but it's bad because it kills. So so we have to be a little careful. And that story really drove that home. And I tell patients, don't use hydrogen peroxide. So, you know, so I'm kind of going back on my word a little, but limited.
Yeah. So in an oral surgery practice or a surgically based practice, you know, just to pivot, because we have a lot of AO listeners that are surgeons as opposed to more our listeners are more general dentistry. We've had a lot of surgeons talking about what they've been thinking about with suction. Typically in an oral surgery office, or most that I've been around, you've got a relatively small lumen to your, I use the word lumen in a podcast, a small lumen, a small opening in your suction, right? Because you want to be able to be pinpoint accurate with that suction and not have this giant suction. So that's good when you're talking about blood. But when we start to talk about aerosols, when we start to talk about taking out third molars or implant surgery, bone reduction, and we're seeing aerosolization, what do you think people should do about that, especially in an office that doesn't have, like general dentists, we kind of have an advantage there because we tend to have these big suctions in general. So what do you tell a surgeon about that? What do you think they should look at as far as some of the technology that's out there to help to reduce the aerosols that are in the operatory?
Excellent. So I approach that twofold. One is the practical, and then the other, we'll talk a little bit about some of the newer technologies. The practical is that we just need to modify a little bit what we do, limit or don't use ultrasonics. Wear obviously a good mask with a good a shield or fit on it, and then wear a shield. Now, for people who have not worn shields, I'll be honest, and I traditionally have not worn a shield. I've worn glasses with little, just glasses. And it's very difficult to listen to someone when you have a shield on and they have a shield and you're talking and it's reverberating back and forth in your shield and it bounces to the back eventually and then it comes back and then they can't hear you because they've got a shield that goes maybe partially over their ears and it sounds like we're underwater. So I think we're going to have to come up with a dental special ops tactical system where we have a hand signals, that goes like, something like,
Perfect.
Kind of like, special ops. Now I say that kiddingly, but seriously, it's difficult to wear all this and practice. So it's a balance, but wearing a face shield, wearing the mask, limiting what fluids, irrigations, maybe modifying the lumen, maybe going back to a little bit larger lumen size may be important. And then also afterwards, making sure that we scrub the rooms, we either use UV light, and some of the newer technologies that are really being advertised now and may or may not work is hydrogen peroxide vapors that lay out and go into the room. UV light can be used in a ventilation system. There's one, for example, Vita Shield, and it's kind of an interesting concept. What they do is they take the panels in the those drop-down ceilings, and they literally just took a fluorescent bulb and they put a fan on either side. On one side, the fan pulls light through. They have a UV light, and then it comes back and it comes out the other side, and so it circulates the air. Now, are there a lot of studies? Not a lot, but there are one or two, and I'm impressed that they actually have one or two because I've looked at other systems, including some of these hydrogen peroxide systems, and I cannot find many studies. And one company said, oh, yes, we have a study, and they showed me the study, and at the bottom it said, for internal use only, and it went on with a few other disclaimers, and it's like, okay, well, I'm not sure I buy that. And again, we all want to practice based on evidence. We don't want to just waste our money because these systems are not cheap. They can add up.
Exactly.
But wearing the shield, wearing the mask, scrubbing down the room, using a UV light if possible. And, we're having to start to look at other systems and other concepts too.
There's been this back and forth about what we do and who really tells us what to do. And in dentistry, we have lamented a little bit, John and I, that we as dentists haven't done a better job at setting a standard for ourselves. And I'm not looking for someone to walk in my office. I'm not asking for someone to walk in my office and tell me what to do. I'm not asking for that. But one, I think we need to be leaders, press for research into these areas so that we know what's necessary, right? Necessary to mitigate our risk and help our patients achieve the best that's possible in our office. And that's why we like the AO, but John, where and where do we get our information, right? Yeah. Because we've had this discussion over the last couple weeks about who writes and who controls what you do. And I know you've had some interesting things that have happened, Robert Lemke, in Texas as we have in Tennessee. John, you want to speak to that a little bit?
Yeah, I mean, as a perfect, I think, segue, as you said, you're looking at the bottom of the advertisement and it says for internal use only, and that's why we love, working with organizations like AO, and obviously this is the AO podcast, but we're members of the AO long before we were partners with the AO, and the whole idea of organizations that are evidence-based, because it's not good enough to say internal study, on file, data on file or something like that. We need to demand as practitioners, as doctors, as hygienists, as everyone in this field, a high standard of evidence. And that's what AO is all about. And I think that, Texas has been interesting because we watched how things evolved in Texas, because Tennessee was kind of right behind Texas, and we were looking at Texas, and some interesting things happened where recommendations changed or requirements changed almost on an hourly basis there for a couple of days, right? I mean, it was the Wild West of Texas there for a minute. And I mean, what's happening with this, and how does this bring us back as we kind of conclude tonight? How does this bring us back to where do we go for the evidence? Kind of talk about, maybe as we close, what happened in Texas. What do you think is going on as we're juggling all this information? And then, kind of tell people, where do you feel like they should be going to look for the best evidence, the best science? How can they plug into that?
Mm-hmm.
Well, this is, yes, such an important part of having good leaders. And that has to happen on so many levels. And some of it may even step on people's toes because politics is involved. And unfortunately, though, it's a lot of the politicians that make rules that govern how we practice. Okay, I'd like to think otherwise, but that's not necessarily the case. So in Texas, if we look at everything, really the only person that can take away someone's license is your state board. Mm-hmm. The ADA is a wonderful organization, but they don't have any weight. They don't have a hammer to enact laws other than representing us. Now, I think as dentists, we've really fallen into a bad trap. And part of it is, and I don't want to say corporate dentistry, but what happens is a lot of dentists coming out of dental school have joined corporate dentistry, and that's fine. But there's no time or incentive for them to join organizations like the ADA or their state organization. And why? Well, because it takes away from production, obviously. And so in many cases, not all cases, but in many cases, it's all about the bottom line, the numbers, the economics. And so the voice of all these new dentists that are coming out is not being heard. And so they can't have a voice on a political level, a federal level, or even a state level. So that's sad. And I think you guys are hit the nail on the head. I mean, people just need to get more active in their states and their state agencies and their state organizations and the ADA and then the Academy of Osseointegration. I mean, I've fallen in love with how it's run, the people behind it, because it's evidence-based, and it's not about, well, in my hands, or, let me show you a case that looked good. And that's really so important, because that allows us to practice our best. And that's what we want to do at the end of the day. We want to be our best. So in Texas, I was giving a talk to another city, and it was really funny because in Texas, the governor, who does have the ability to create executive orders, okay? So the governor put out an executive order, and the executive order read that dentists essentially should not be practicing, or healthcare professionals or dentists should not be practicing unless there was active bleeding where they were going to die or an airway issue. And okay, well, that limits it a lot.
It's pretty strong.
Yeah.
Very strong. I mean, no questions, okay? This very next line said, but this does not apply if you don't use up PPE for a hospital or have a patient that might enter a hospital and take up a bed, essentially. Now, the ADA and the TDA left out that second line and just said, don't practice. And that's what was advertised. Well, later, there were 2 more executive orders. And by the third, 1 extra line was added that if you had a state-approved hospital facility, then you could also practice. So what did happen was, that was the governor's, the executive orders. The Texas State Board then wrote their own orders and said, well, according to the governor, all dentists are not state-approved facilities and so cannot practice.
Oh my.
But that's not what the governor said. And I was going to point that out. And my wife, I told her this. I said, the state board is completely wrong. And she said, no, it's not, Robert. And I pointed it out to her. And she's a very bright person, and she does copy editing for a lot of journals and articles in dentistry. And she looked at it and said, okay, well, you're right, but I wouldn't say it. It's like, no, I'm going to say it. And she walked out like most of our wives do, shaking her head, you do what you want. Well, 3 hours later, and like you said, I mean, it changes by the hour. There was an amendment by the Texas State Board that said, oh, well, now we're not following the executive order. We're going to follow the CDC guidelines, which says only bleeding or airway compromise. Well, the funny thing is, I thought, okay, well, let me look at the CDC guidelines. So I looked at the CDC guidelines, and they said, our guidelines are based on the ADA guidelines.
It's kind of crazy. I mean, there's so much to this, you know, the tail wagging the dog sometimes and the dog wagging the tail sometimes. And you got, you know, all these organizations, and really, as we've talked about, and we don't want to go too far down this rabbit trail, but, you know, no, it's really about liability. You know, no one wants to accept liability for making a decision that could affect someone else's life, even though that is what their very job is to make decisions so that we can. We talk so much about leadership in this podcast, and we need that. We've called for that multiple times on our podcast, is just good leadership and discussion amongst these organizations. We just had it happen in our state. And again, I won't go into this too far, but the other day we were told we could go back. The governor said we could go back. Everything was going great. We went back. The day we went back, midday, Tennessee OSHA drops this bomb on us saying postpone elective procedures. Within hours after that, TDA, Tennessee Dental Association, sends an email out saying, basically, just kidding. You know, the Tennessee OSHA released the wrong guidelines. They're actually revising that, and that will be re-released to follow the governor's order. So, you know, I mean, in a matter of hours, you can go from things are going to be great to things we're never going to go back to we're back. And I think that this just goes back to, again, all that we've been talking about this evening.
Best practices.
We have to first look at the evidence and develop best practices. That doesn't mean, as Robert, you said, we can reduce everything to zero, but it means that we have to use evidence-based, common sense and evidence-based practices. And we need to seek out the groups that are. I think this has been an amazing discussion. I think that, you know, there's a lot more to this, obviously. And I think what I would refer people back to, if you want to hear more from Dr. Lemke, I mean, just recently you did a couple of webinars for AO. If you're an AO member, you have access to those, I believe, at no charge. If you're not an AO member, go check that out and see if you can get connected to those, because this goes even much deeper into the virus itself. You talked about, you know, telling us more about the virus, some of the epidemiology, and then the pathogenesis of the disease. Very good stuff. And then a lot on PPE. So I think, you know, go back and get more. And you mentioned your Instagram too. You guys are actually putting stuff on your Instagram, your office Instagram, on some of the testing and PPE you're doing. That is very cool. I just got to ask,
who's in charge of your social media?
Do you have somebody do you have somebody who's putting that up there for you?
I have 2 staff members who do that, and, you know, they love doing it and they're good at it. And so I give them a few ideas. I'll say, hey, why don't we do one on this? And they run with it. So you mentioned earlier, surround yourself with great people, and we are only as good as our staff. I mean, we all know that. I mean,
sure.
patients will come back to us. We'd like to think it's because of us, but we know the truth is that it's a team. And without having the team and having good support from our taking care of our administrative and our assistants and our nurses in our offices, and if we don't take care of them, they can't take care of us.
That's right.
And together, that's where it really works. And you
and
guys,
if they
I mean,
feel, and if they feel like all the things you're doing in your office, I mean, isn't it amazing the response that you get from your team? My team, even though some of them were a little nervous, when you engage together and you discuss what's going on and you dive into the evidence together and you show them what you're doing, I mean, frankly, we're spending a lot of money. We're spending a lot of time. And I'm not, I mean, some of that's very stressful, but on the other hand, if you share that with them and you go through with them what you're doing and you kind of show, hey, we are trying to develop best practices together as a team, man, they have just, I mean, I'm humbled by the things that my team has said to me about this, because obviously not everybody is, some people have the approach of just do the minimum. And, I think that in the long run, the reason why some of our practices may come out of this stronger is because we're able to, show our team, lead our team through this, hopefully showing that we care about the best things we got. And obviously you're doing that. Wes, go ahead and close this out, man. This has been an amazing discussion.
Yeah, I really have enjoyed getting to know Robert Lemke, and over the past week we've spoken several times on the phone. And John, I can tell you enjoyed it tonight. I kind of let you roll a little bit because Robert and I rolled for probably 30 or 40 minutes the other day, and it was a great conversation. And I tell you what, I'd like for Robert to tell us a little bit about what he's up to now and what's his next big thing with the Academy. Plug some of your stuff because we want to know what you're doing next. And I'm just going to go ahead and say it right now, John. We want to have Robert back on our show, and I want to talk some stuff, right? And we'll kind of in the post show here.
We're going to geek out.
We're going to geek out just a little bit on another show, but in the post show, let's talk about our next time that we can get on. Robert, where can people find you? How can they reach out to you? And what's your next big thing with the Academy of Osseointegration?
Well, they can reach out to me through the Academy of Osseointegration. They just contact them and they can contact me. Of course, obviously, they're always welcome to email me directly. And we can give them that email on your websites or on your later. We can include that so that they can look that up. The latest thing, and we were chatting about this, Wes, just earlier, is that the Academy is just a wonderful group. And John, you mentioned, and you both mentioned that surround yourself again with great people. When I was honored to be on the board, I sat down and with some new people, and everyone goes around the room and introduces themselves. And, there's a dean of the dental school, and there's, a chairman of the program in Harvard and UCLA and Penn. And they just go around the room and it's like, wow, oh my gosh, wow. And then they get to me and it's like, I'm an oral surgeon, so I'm just humbled to be around them. But I think that's what's inspiring to me, is that being a part of this association, every day you can just literally contact them and they are happy to spend time with you to help you out. I mean, their heart, their soul is all into taking care of the members. We were going to have a meeting in Seattle and we had to cancel. We were one of the first large company or corporate organizations in the United States to cancel. But we did that because they wanted to take care of the members. Now, in the future, we're looking at more of online blogging where people will be able to interact with each other. And that's actually what I'm now been tasked to put together. So I was working on a little of that last night with our president, Dr. Clark Stanford. and be working with some more. And I'm looking forward to doing that and bringing in new students. We have scholarships for students for the next year's meeting. Hopefully we'll all get to go, where we have travel grants that help support the students. And that's where it's exciting to hear these people. And they're students. They're also people who are older who just came up with a research project and are presenting it. And that's what's so fun, because it makes me think outside the box. And that's where the honor is to be with all of them.
Awesome. Well,
thank you.
I think
this has been fantastic.
Yeah, it has. It's been great to talk through this.
Well, listen, if you're listening to this and this is your first time hearing the Dental Guys, first of all, we want to thank you so much for listening to this live stream podcast. We have been working with the Academy over the past, say, 6 months to produce several of these that we'll be letting out over the next year or so. And we're super humbled to even be asked to do that. So I need you to go give the Academy of Osseointegration some love. And how you do that right now is, if you aren't following them on YouTube, you need to subscribe to their YouTube channel. Another way that you can support the AO is to go subscribe or like and follow their Facebook page. They're all the time. Listen, they have been one of the most active organizations when it comes to putting out just good quality content. And Robert Lemke is part of that content that you're seeing streamed out through webinars and how-tos, how to get back to work. What does the science say? I mean, he has a video out there of how to walk into your office, don and doff your PPE. And I thank the AO for allowing us to bring Robert on to talk a little bit about some of the science and what it says. If you're a Dental Guys listener, hey, listen, we want to continue to bring you content, and how we do that is for you to share it with a friend, with another colleague. I really appreciate all those that have joined us over the last few weeks. This has been fantastic. We appreciate you more than you can know. Please leave us a 5-star review on Apple Podcast or every podcatcher that you have, and I really appreciate, again, the AO for doing this. So for Robert, for John, I'm Wes. And this has been another great episode, and we are the Dental Guys.